Yes, good morning. Can I hear you?
Okay, thank you. Thank you. I'll be starting in the next 5 minutes because I'm supposed to be going. I'm having a workshop. Please ask your colleagues to join in. Okay, good morning. I'll be starting. Faith, is that okay? Hello, can you hear me? Hello?
Yes, we can hear you.
Thank you, Victor. So, Victor, do we start or what do we do?
I think we can begin as the others joined.
Yes. We'll also do a recap when I'm available. Okay. Yeah. Let me say when I'm available, when I'll be coming. We have been up and down doing these workshops and projects out of Nairobi, out of JQuat, etc. So Dr. Ubera was sitting in. Then I had told Faith that I need to do a makeup, and then she says we do it today. And so in the middle of my preparing for my workshop and presentations, I had to do this so that at 9 I'm in the room for the meeting. It's an interesting meeting. With time, I'm hopefully going to roll it out in JQuat, and you're one of the people who will benefit from it. Okay, so my apologies that I have not been around, but I think I only need 1 more week to finish all the things that we've been doing. Actually, we also have the cancer month, October, which has flown to November, and I do a lot of work for cancer at the national level. So I've been in and out. I've been in and out doing all that work and setting up places for diagnosis. So that's why I apologize that I'm not there, but I will make up for this once we finish. Okay. So my apologies. Now I'm going to talk about hypertension. Let me share my screen. Just a minute. So we're going to discuss hypertension. I'm wondering, I'm using a different gadget. I think I have too many problems. Slideshow. I want you to tell me whether you can see my screen. Can you see my screen? Is it on slideshow?
We can see the screen, but not on slideshow.
It's not on slideshow, eh? And this one doesn't have the option of read only. I'm using a different gadget. I wake up, I slept very late preparing different things. And then all of a sudden, the laptop I was using has decided to go to sleep. So I have been given another one to use. We will just do it from this because it doesn't have read only, and so it doesn't have the option of slideshow. But are you able to see this?
Yes, we can see it.
Okay. We'll just do it using this. The slides that I hide, I will continue hiding them for now. So we are going to be looking at hypertension. I think it's something that we always say hypertension, and we're telling each other hypertension. But what is hypertension? What is hypertension? The most important thing that we need to know is it's a silent killer. And that's why I put this slide there. It is a silent killer. And why do we say it's a silent killer? Because we are hardly going to look to check our pressure. We are hardly going to check how our blood pressure is doing. The normal things that we say, wellness. You need to check how is your blood sugar, how is your blood pressure. When you're becoming older, we look at your lipid profile. We look at some PSA tumor markers. Examine pap smear or HPV testing, etc. We'll talk about those in this systemic pathology. And I say that because we are hardly checking. So sometimes you'll get like maybe a headache, and they'll say, now mama na kichwa. And what do people do? They just take a painkiller, not knowing that a headache is representing something bigger. And so with time, you've been taking a paracetamol in a reduced kidogo, you're able to do your things, but you continue without going for a checkup. And unfortunately, by the time now you come for a checkup, or by the time things become really bad, is when you're coming to the hospital. Maybe you already have a cerebral bleed, what you people call a stroke. Or it might be so much that the bleed is causes death. So that's why we say it's a silent killer. And today, before we even go to our learning objectives, what I would want us to know is that we need to preach this gospel of checking up, checking on monitoring our BP, our blood pressure. Okay? Monitoring, we'll see complications that can come with high blood pressure, many things that can come up. And therefore, let's preach when we go for our December holiday, let's preach in our villages about checking on our blood pressure and look at different methods of how we can check on our blood pressure. Okay? So I call it a silent killer. And 17th May is usually the World Hypertension Day. I just look for this slide just to talk about that. So these are our learning objectives for today, that we will define. We're going to define systemic hypertensive vascular disease. Why do I call it systemic hypertensive vascular disease? My reason for calling it systemic hypertensive vascular disease is because in this semester, I think it's either me or Dr. Obero who will talk about portal hypertension. Again, that's a form of hypertension. So we are talking about systemic arterial hypertension now, vascular arterial hypertension, so that we don't get mixed tension for liver. This one is the one for arterial, systemic, vascular, the whole system in the vascular. Okay, so we will define that. Then we will look at how the normal blood pressure is regulated. You will remember from the last semester we were not able even to teach your group. The time we taught you general pathology, I told you pathology or disease is abnormal structure and abnormal function. Okay? Therefore, for us to discuss a problem with hypertension, we have to high blood pressure, a problem with high blood pressure, we have to know how we regulate the normal blood pressure. So we will review, because this is something you did in physiology. However, we will review how we regulate our normal blood pressure. Then after that, we will then define and come up with hypertension, how you classify it, the different ways of classifying. We look at the different etiological and pathophysiological methods of this hypertension and how patients present. What is a clinical manifestation of this hypertension? Okay? And look at the morphology of this presentation, especially because we are dealing with systemic hypertensive vascular disease. What are the changes in the blood vessel in hypertension? Then we look at the complications. And one of the complications is in the heart. And so we will finish by discussing the hypertensive heart disease. Okay? It's not going to be a very long class. Okay? Most of it is diagrams and most of it is something you know because you've done the normals. Okay? We're just going to be helping ourselves to come out of things that we have many times believed myths. We now understand the real thing. And therefore, what is hypertension? It is persistently elevated arterial blood pressure. And that's why I said it is vascular, arterial blood pressure. We've done blood vessels, so we remember where we are at the arterial level. So it's arterial blood pressure. The different methods that we use to measure this blood pressure and can be done at different sites. And therefore we use this when we're defining whether the patient is hypertensive or not. Okay. I pause there and ask, which methods do you know that can be used for measuring blood pressure? Which it can either be, you want to talk about the gadget that they use for blood pressure monitoring or the method. It's open, you can answer. We have to interact. Blood pressure monitoring. What do you know? You've been going to the hospitals, etc. I even saw in your timetable. How do you measure blood pressure? I'm sure most of us have been done that. When you go to the hospital, they check your blood pressure. What did they use? That's what I'm asking. You can type, you can unmute, because people
We
are
use
usually,
we
yes,
use
Julius.
yes, we use sphygmomanometer.
Yes, a sphygmomanometer, correct. Mm-hmm. Faith, I saw you typing, but then you can say blood pressure machine. It's the sphygmomanometer. Then we're having new ones which are digital. We have the old ones where we used to look at the mercury going up and down. They have different methods. That's all I'm asking. I wanted to know whether you know that there are different methods using that machine. And there are different sites where you can do. You see, you could be coming to the office, we do your blood pressure. So we look at when we say that someone has increased blood pressure when they're doing the one in the office. You can have pressure monitoring at home. With the digital blood pressure machine. Actually, that digital pressure machine, you'll find many people having it, even in their homes. I think it costs about 4,000 or 4,500. Okay, that digital one. Okay. Then we have the ambulatory one, where you see someone with gadgets, a gadget, a device on the arm, which is monitoring continuously. Okay, at 24 hours. Then we have the ones, and I want to show you a photo. I thought this is very important so that people can know that there are different methods. And so we usually get an average of this to say someone has high blood pressure. But I will define for you what we call high blood pressure or hypertension. But these are just incidences. I wanted you to know that if the patient came to the office or your office and you did the blood pressure, when do we say that it is elevated, persistently elevated? Of course, you have to take after 2 occasions and it's high, then you will now start thinking it is hypertension. If it's at home, above 135 and 85, we'll look at that in details. And if it's ambulatory, this one which is taking throughout the day. So they get an average. I want to talk about this before I move, about sites. We can have what we call a white coat hypertension. This one occurs when the patient comes to the hospital and they just see you in white coats. Stress goes up, adrenaline, hypertension. Okay? So there are changes in the vasculature and then the pressure just goes up. They are not hypertensive. This is occurring because of, we call it white coat hypertension. It's because of seeing the white coat in the hospital. And that is why sometimes you'll find some people saying if you did the ambulatory one and gave the average and brought to the hospital, then it will be a better assessment than just the white coat. So one of the ways of overcoming the white coat hypertension is using the ambulatory one or them monitoring at home, where you're not afraid that I'm in a hospital and I'll be told I have this disease. Okay. Yeah. So I show you the different ways. This is in the office or in the hospital. You'll go read about it. I'm sure you practice it. So I don't even have to mention. There's a positioning of how the patient should be positioned. Here you're using the digital BP machine in this patient. Okay. So they sit upright, the back is supported. Then you want to the left arm to rest properly. Okay. And then you get a fitting cuff, the thing that you tie around the arm. And then the arm is resting mid arm at the heart level. You see where the heart is? This is where it's resting like that. Then you take the pressure. Okay. Of course, you have to be in a quiet room, make the patient comfortable. like I usually make sure that my patients have rested. They first sit at the reception, they wait for some time, relax, and then take the pressure. Otherwise, if there was activity, it may be elevated. And then this, by the way, disclaimer, I just picked it. The one I had picked for you has refused to show on this laptop. So do not call this number. I don't even think it's a Kenyan number. I just wanted to show you the picture of the ambulatory blood pressure monitoring. That they usually have a cuff on the arm, and then the gadget is here, and then they'll do an average. So they'll move around with it during the day, everywhere they're going. Then you can do measuring during the day and at night and get the average. Okay. And yes, these gadgets are there. They're there, which we can use for monitoring. So the other one, that this the previous slide is what refused to show on this. This one is where we measure now using the auscultation method, or you can even still use the sphygmomanometer, where you see the rise and fall of the mercury. So here you listen to the Korotkov sound. So this is the method for measuring. Okay. Again, you tire the arm. Okay. Make sure you put the stethoscope in your ears when you want to listen and auscultate, then you'll hear the sound. Okay. Yeah. All these methods I'm talking about, they're easier, practically done. So when you go to the hospital, make sure you do them. And I usually recommend you do the sphygmomanometer one on top of digital. Why? The way we usually look at the quality or control the digital is using the sphygmomanometer or the auscultation method, this one. So when you go, please make sure you have practiced. You have practiced. I don't know that you people do that course called nursing skills, because one of the things in nursing skills is looking at the vital signs. And so this is one of the methods. Okay. So let's move to, those are just the methods that we can use for monitoring blood pressure. And we said it's elevated blood pressure, but we'll need to define it using the methods that are known worldwide, okay? Global. So what is hypertension, or what is elevated blood pressure? When you say persistent elevation of blood pressure, what do you mean by that? So we will refer to the European Society of Cardiology and the European Society of Hypertension. This is how they, if you look, even it's similar to the American one. This is how we categorize or define hypertension. Okay, let's first look at normal. What is a normal blood pressure? Because the thing which is abnormal becomes the hypertension. So optimal, we want to have our blood pressure at less than 120 systolic and less than 80 diastolic. I repeat and I explain what I mean. So systolic is the numerator and diastolic is the denominator. Okay, is the denominator. So the optimal we want to have is when somebody has less than 120 numerator and less than 80 denominator. That is systolic and diastolic. Okay, that's the optimal one. So the normal is between 120 and 84 for the diastolic. You can look at my table there. So when you see someone is having a high normal, then they're having pressure between, for the systolic, which is a numerator, at 130 to 139. Then the denominator at 85 and 89. Okay, so this is very important that we classify, because that also helps you in monitoring your patient, because there are different methods that you can use for monitoring that is elevated. Okay, so you look at this even at your free time, how we can even grade the hypertension. Okay, after the high normal, you can now have grade 1, where you have between 140 to 159 systolic and 90 to 99 diastolic. Then we'll also have grade 2. This is 160 to 179, and then 100 to 109. And then grade 3, which we see a lot with malignant hypertension. I'm going to discuss that in a few. It's when it's greater than 180 for the systolic and above 100 above or equal to 100. Sensitive ground because it can easily rupture the vessels in the brain, etc. Okay, by the time you're getting to grade 3. Okay, and then there's also a form of an isolated systolic hypertension. We call it isolated because the systolic is above 140, while the diastolic remains normal. This we'll not discuss at this level any further. Let's discuss the major ones, the must knows. Okay, yes, which is this class? Please take home this classification is important. Okay, and that's how we'll define our hypertension. Okay, so this is the actual definition and grading. Sorry, it's not classification. This is grading. I'll classify in the next slide. Okay. So let's move to, we've said hypertension is when the blood pressure is high. So how do we monitor blood pressure? Or how do we regulate normal blood pressure? I pause there and ask the class, how do we monitor blood pressure? Or rather, how do you regulate normal blood pressure? What you learned in physiology. What was the normal regulation? What are the things involved in regulating blood pressure? What are the things involved in getting, what was the equation we used to use for blood pressure? What was the equation you did in physiology? Which equation did you use to mention blood pressure? You used to say blood pressure is equals to dash times dash. Anybody? I'll call out names on the chat box, on the list. Julius has said something. Lorraine Onsongo. That equation, it was blood pressure is equals to dash times dash. What was that, Lorraine? Lorraine? Are you there, Lorraine? Oh, you're not there. Hello? Are you people? Can you hear me? Oh, so Lorraine, what is the equation? Oh, you did listen only, eh? You can unmute. Please, just let's be in a discussion. Julius, can you speak?
Yes, I can speak. The equation is blood pressure is calculated by cardiac output. We multiply by peripheral vascular resistance, PVR.
Yes, that is it. That is it, Lorraine. Eh? You people, you have forgotten physiology. Thank you, Julius. You've forgotten. It's, as I said, pathology, you have to remember the normals. And this is the equation that Julius has just mentioned, that the blood pressure will be equal to the cardiac output, and you multiply by the peripheral resistance. And therefore, we have to look at the things that cardiac output relies on. One of them is the blood volume, the mineralocorticoids, especially sodium, okay? And the other things that regulate it, including your ANP, that is atrial natriuretic peptide, and other cardiac factors like how well the heart can contract and increase even the heart rate. Then we look at the resistance in the peripheral. This is at the arterioles. Okay, mainly it's the arterioles. So there are things that would affect the arterioles and make them either constrict or dilate. And those are important things because once you've constricted, then you've increased the resistance. And therefore, this equation goes high on this side, and therefore the pressure increases. Okay. And then we have even local factors that you can have autoregulation, even at the level of the arteriole. Sometimes if too much blood is coming in, they're able to sense and constrict. This time they're just protecting that organ at that moment in time. Okay, then other neural factors where we'll have constrictors like your alpha adrenergic receptors, and then the dilators like your beta adrenergic receptors. So those are important things that we have to remember. I put down just a little literature here, just explaining this table, which is what you did in physiology, but it's good for us to remember and review that for the cardiac output, mainly it relies on the blood volume. Okay, and this blood volume we know very well is reliant mainly on sodium concentration. And in my next slide, I'll discuss about the role of the kidneys and the adrenals in regulating sodium. You remember your renin angiotensin system? We'll discuss it because it's very important also in blood pressure regulation. When you look at the PR, which is the peripheral resistance, it's mainly at the arterioles, okay? And as I said, it's regulated by the neuro and the hormonal inputs. And therefore, the tone at these arterioles is just an interplay, it's a balance between vasoconstriction and vasodilation. And remember the chemical mediators that help with dilatation and constriction. Okay. And as I said earlier, they can also do autoregulation by themselves. Okay, just to protect the organ at that level. Okay. Then other factors I already mentioned, like your, environment, the pH, when you have hypoxia, etc., and the neural interactions that can occur. Okay, and I'll talk about this as we continue. And therefore, this is very important that we see the interplay that occurs on this. And this, anything that raises our cardiac output is going to raise our blood pressure. So if we are retaining more sodium and therefore having more blood volume, then the blood pressure will increase because the cardiac output will have increased. If we are increasing our peripheral resistance, for example, we have vasoconstriction occurring, okay, either because we're having the alpha adrenergic or we're having any chemical mediators, then the peripheral resistance will increase and therefore our equation will increase and our blood pressure will increase. This is mathematics. Mathematics. Okay. And this you've seen it so many times. It's just reviewing it. Let's look at the role of the kidneys, which is a major, plays a very important role. Okay. And then the other part is the adrenals, which help in regulation of this blood pressure. Okay. And I show that in a diagram so that you understand. And this is okay. Yes, I think you can see my diagram. Okay. So this is just looking at the renin angiotensin system, which helps to regulate the blood pressure. So this we are looking at the role of the kidney and the adrenal gland. Okay. So here we are in our kidney. And what does the kidney do? Kidney is going to sense that there's a drop in the blood volume or the fluid volume in the body or a drop in the blood pressure. And so what does it do? In the juxtaglomerulus apparatus, they're going to release renin. Okay, so when renin is released from the kidney, it's going to act on angiotensinogen, which is secreted by the liver, and convert this angiotensinogen into antioxidants. Lung is going to release our ACE. ACE is angiotensin converting enzyme, the ACE. I know you know that because of drugs. Okay, so the ACE is then converting our angiotensin 1 to angiotensin 2. What does angiotensin 2 do thereafter? It's going to act on the adrenals. So in the adrenal gland, it's going to act to stimulate the release of aldosterone. So aldosterone, this steroid called aldosterone, is the one that is going to act on our kidney again. And what will it do? It's going to act on our kidney in the proximal tubules, in the loop of Henle, etc., to stimulate reabsorption of sodium along with chloride. Okay? And therefore, you change the osmotic gradient. So when you reabsorb sodium, then you reabsorb the water. And therefore, you go back and increase our volume. Okay? You increase our blood volume and therefore our blood pressure because we have reabsorbed. Okay, we have reabsorbed water, so the volume has gone up and the pressure has gone up. So that's how they regulate. So if the opposite happens, like the pressure is very high, we will decrease the release of renin, and all this now happens in the opposite direction. So it is very important that we remember our normals. Why? Because when we talk about disease or pathology, we'll be looking at things that will cause a problem in either we're having high renin production, like a renin producing tumor, or we're having a problem with the adrenal gland with this aldosterone. Are we together? So that's the disease process. And that's why we'll be looking for so that we can treat. So once you have understood normals, disease or pathology is easy. Okay? Yes. So are we together till there? Are we together till there? We have talked about different ways of checking the blood pressure, and we've defined what hypertension is, and we have gone back and reviewed our normal regulation of blood pressure. And therefore, now we will then move into talking about the types. Which are these types of hypertension or high blood pressure? We've seen how they're regulated. So, which are the types? Which are the types? So we have two main types. We could call it this way. Some books will call it look at it differently. But I like looking at this way, this way, and my reason is because I'll be able to capture malignant hypertension and not leave it out. Again, please don't get confused with neoplasia. We discussed in general pathology. We talked about neoplasia and said there's benign neoplasms and malignant neoplasms. Now, again, these are just terms we are using in hypertension. Please, it is not cancer. Okay, it is not cancer. Please don't get confused. It's just a term that we use, but it is not neoplasia. Okay. So we say benign hypertension and malignant hypertension. So under benign, we divide that into two, which is what you'll find most books saying, that the types of hypertension are essential hypertension and secondary hypertension. Okay. And essential takes about 90 to 95%, while secondary hypertension is about 5 to 10%. Now, the reason I put my malignant here, instead of just classifying it as essential and secondary, is because I want it captured. I do not want us to miss out on malignant because it's there and it can happen. And therefore, my next slide, I'll describe this malignant hypertension that I have brought around. Okay. So what is malignant, or what we call accelerated hypertension? Accelerated hypertension. First of all, it occurs in about 3 to 5% of patients. And in these patients, what they do is that they will show us a rapidly rising blood pressure. And if you don't treat this rising blood pressure, that one of where we were showing you grade 3, 200 over 110, that one. If you don't treat it, many times these patients will die within a year or thereabout. Okay. In fact, some of these patients have come when, sometimes they have a bleed in the brain. Okay. So it's a syndrome that is characterized by three things, many things, but one of them is the severe hypertension. And mainly here we look at diastolic denominator, that the denominator can be even above 100 millimeters of mercury. Denominator. You can imagine from your normal 80 to 120, the damage could be big. Okay. Then they also usually have renal failure. And then if you do tests if you check on the eyes, they'll have retinal hemorrhages with exudates, and sometimes with papilledema or no papilledema. Again, we're not going into details because we're not in systemic pathology. We look at those as the systems come along. But this is what we see in these patients. They will have severe hypertension. We are monitoring their pressure. It's high. They have renal failure. They have ocular problems with hemorrhages and exudates in the retina. Okay. So, and what is important is that this malignant hypertension usually can be found in normotensive patients. What do you mean by normotensive? People whose blood pressure is optimal, normal. But more often, many times, it's found as a superimposition on people with persisting benign hypertension. Okay? Okay, either the essential one or the second one, and I'll explain now essential and secondary hypertension. So that's the reason why I said we have to touch on our benign and malignant hypertension. Okay, that's the reason why. Okay, yes. So we move on to essential hypertension and talk about it. Essential hypertension. So for the essential hypertension, this is the one that is a common one, very, very common. As I said, it's 90 to 95% of cases, okay? And it's one that we say it's idiopathic. We are really not 100% sure of what causes it. So we play it safe and say essential hypertension. However, studies have shown that there's a genetic problem somewhere along the way. And then we have environmental factors which modify or make the genetic thing to be seen or to become worse. Okay? Yes. So that's usually what happens. Many times we really can't pinpoint what causes it. point, you can't come and MOPC. And I'm here saying this essential hypertension is because the sodium pump is not working, something like that. It's really just there, not 100%. That's the way to say it. So we play it safe and call it that way. However, we look at the different genetic or environmental factors that the hypothesis of how they're playing to cause this essential hypertension. So for the environmental factors, is those things of stress. Again, during stress you'll release the stress hormones. You activate your sympathetic nervous system. Okay, so you'll have your adrenaline coming up, and then what will it do? It will act on the neurofactors in the peripheral resistance and increase it. Then you end up having hypertension because the peripheral resistance is going to be high, for example. Okay, so other factors: obesity is associated with diabetes. Of course, affects both neuropathy and vasculopathy. All these things. If you look at smoking is involved everywhere. Okay, lack of physical activity will lead to obesity. So these are the interplays. Okay, if you have heavy salt intake, then you're having a problem with your renin and angiotensin system, then you're having excess salts. So all these are the modifying factors, we'll call them. Okay. So in this essential hypertension. Okay. So if you look here, this table is just trying to show us the hypothetical scheme of the pathogenesis of essential hypertension, where we look at the genetic influences. For example, we have a defect in the renal sodium hemostasis. Either there's a problem with reabsorption, at the level of the membranes, for example, there's a gene missing, okay, or an enzyme. So we'll have inadequate sodium excretion, okay. And so what happens if you're not removing the sodium from the body, then we'll retain that sodium. And what happens? The osmotic gradient is increased, and therefore sodium is going to be retained, and it will pull water along the way. And so we'll have sodium and water retention and an increase in the blood volume. Okay, and now that will increase our cardiac output. You remember, by the way, all these things I'm discussing, you have to remember this table. This diagram, that we are looking at the things that increase cardiac output or peripheral resistance, so that the pressure is high. Okay, so the one I was just describing is sodium regulation, and it's showing here. So it will increase the blood volume. Okay, very important. Let me go back. So this is what I was saying: the salt and water retention, and therefore our blood volume increases, and therefore the cardiac output increases, and we get hypertension. Other things like functional vasoconstriction, like so much stress, etc. We may have the neuro effect. Then you'll have release of catecholamines. Then we'll have vasoconstriction, and which will increase the peripheral resistance. Okay, total peripheral resistance. Again, defects in the vascular smooth muscle, growth and structure of the actual arterioles. Because I told you the main part in the peripheral resistance is in the arterioles. So they'll affect and cause thickness of the blood vessel, which can lead to increase in the peripheral resistance. So this is just a hypothetical scheme of what causes the essential hypertension. And I said we just play it safe. We'll hardly find people going into details of picking where the problem is. We just monitor. Okay, we monitor in this essential because it's in 90 to 95% of our patients. Okay, but now that is essential. What about secondary? Secondary means there's a cause somewhere. And I'm going to pause here and ask the class, what then do you think would be the cause of secondary hypertension? It means, and to help you, go back to the table. Go back to the table. Let me go there so that you can unmute and give me the answer. Unmute and give me the answer, please. Go back to this so that it helps you. Secondary hypertension. What do you think will cause secondary hypertension? A disease process that can increase the cardiac output or the peripheral resistance. I know we haven't done diseases, but think. Let me look at your names again and call out. Millicent Cherono. What do you think? Which disease do you think would peripheral resistance? Millicent? Cherono? I see you are typing. As Millicent is typing, let me see who has, okay, defects in humoral factors. Okay, correct. I wish couldn't mention. I know we haven't done diseases. We've just started systemic pathology, but I know even streets there when you're discussing with your friends, when you're doing TikTok, you have a name. You have disease names, or maybe you even have friends or villagers or relatives who have like a disease with this atherosclerosis. Okay, blood vessel. Correct. Yeah. Now you're thinking. Yes, polycarp, pheochromocytoma. I know we haven't done it, but we'll talk about it. And this one is where we are having an increase in our catecholamines. Catecholamines, correct. Keep talking. Yes, I see Newton is also typing with Rita. Keep typing. And the ones who can unmute, just unmute and say something. Okay, diabetes type 2. Yeah, Rita and Faith talked about diabetes. There's an interplay between the two. Okay, and we see diabetes, atherosclerosis, and diabetes by itself will cause vascular neuropathy, vasculopathy and neuropathy. Okay, so it will be in both areas here. Very good. I see multiple people are typing. I give them a minute to finish. Very good, Timothy. You have looked at the adrenal gland and the aldosterone. Because even if we have high levels of aldosterone, we are having more sodium reabsorption and therefore increase in the cardiac output because of the blood volume. Yes. You see this table, by the way, once you have understood normals, you can create your disease processes from here. You asked etiology and you have it here. You have it here. I'll give you just one more minute for Rachel, who is typing. Okay. Okay. Hyperthyroidism, very good. Chronic kidney disease, very good. Now, in hyperthyroidism, it is by the way, it's not just can cause, it's high, we call this high outputs levels in the body. So thyroid, and even during pregnancy, sometimes some pregnancies where we'll have, I don't know, nobody mentioned in pregnancy where you have preeclampsia and eclampsia, high outputs. So they can cause, and don't worry, because we are headed there. We are going to pick all these things I'm mentioning. Okay. Yes. So thank you very much, class, for this which forms about 5 to 10%, and that is very correct. We'll not discuss each disease process because we are now discussing systemic pathology. So they will all come in there. And like in this, I have put them like the renal causes. Somebody talked about renal causes, and you can see they're all here. Of note, I like mentioning, like look at your renin producing tumors. So renin is high, so it's affecting our renin angiotensin system. Look at endocrine. There are very many things in endocrine. Okay. And it was mentioned in the group adrenal cortical hyperfunction, okay, exogenous hormones, okay, the steroids, steroids that we give. Pheochromocytoma was talked about, growth hormone, high acromegaly, hyperthyroidism, high outputs, thyrotoxicosis, pregnancy-induced preeclampsia or hypertension. Okay, that's a whole topic that we can discuss now. Also, cardiovascular. There are very many, very many in the coarctation of the aorta, polyarteritis nodosa, increased intravascular volume, increased cardiac, many things. Then neurological, including increased intracranial pressure, things like sleep apnea. They're all there. In sleep apnea, many times what you see, sleep apnea is where the baby or somebody forgets to breathe. Okay, okay. You're asleep, then you're. I'm just saying it in lay language. We used to say that in children. Ona aka katoto kamesahau kupumua. Then we slept when I was rotating in pediatrics. Okay, but anyway, sleep apnea. Now because of that part of where they they had a stage of not breathing, the apnea. So what happens is hypoxia. And you remember I gave you in the diagram that hypoxia can also cause an increase in peripheral resistance. So what it will do, hypoxia, will activate the sympathetic pathway, and then you'll release adrenaline, etc., which will work on the peripheral resistance and increase it. Then you have the hypertension. I just, yeah, that's the way it works. Okay. So this one I just put it there, just possible. If they have coarctation of the aorta, we usually can tell that when you're taking the blood pressure, the arm and the leg, pulse, the femoral pulse. So let me not go into clinical so much. Then endocrine, there are all these things. We'll do endocrinopathy this semester. So we will, I think it's either here. Then the apnea I've talked about. And then drugs. Drugs, especially steroids, anabolic steroids, they're really bad. And you've seen that. I'll give you stories. When I was a medical officer, and you know the way you do locums. Yeah, so one of the places where I used to do my locums, and it used to pay well, the rates at that time. And so we used, most of the time then I used to do those medical reports for insurance, etc. I think nowadays they don't overdo it. And some of my clients, I noticed the young men who would actually, they come in, my nurse has taken the blood pressure and it's high. And, you're taking through this, from this patient, there's nothing. But on clocking, you realize that they have been taking anabolic steroids. And it was unfortunate, because I had to keep on canceling them. You see, when you're an insurance agent, sometimes you're able to convince a group of people, and so you bring them. So there's a trend when there's a certain group that used to be brought. These people some of them used to play this game, Rouge. What is it called in English? Rugby, and I don't know. Then they'll say, "Oh no, doc, kuna concussion ingine," and they're big, they're huge, all this muscle hypertrophy and all, and they have this, they say some nutritionists give them, nutrition, protein, something, some funny thing, and it was a trend because usually in young people, you suspect, if I see a young person having high blood pressure, meaning it's not essential many times, I have to look for the cause because it's a secondary hypertension. And these are some of the causes. So they were taking. Other times that have got people, or rather been able to evaluate, is when they're having a pheochromocytoma. Pheochromocytoma, I have seen that also of adrenal. Okay. The rest endocrine, they're there. Okay. Some people have Cushing's syndrome, and the Cushing's syndrome was because of exogenous steroids they were taking. Okay. So, and then leading to hypertension. So these are cases that you will see. These are cases that you will see. And my nurse now became hypertensive. She told us she was going to a place, I don't know, the ones who know Nairobi a bit. There's a place they call Mombasa House, where they get all these facial brightening. What are they called? The whitening creams, or they want to become blonde, or yellow or something. So she would use that and had used for a long period. And by the time she was coming to the clinic, and I remember her telling us the truth and advising us not to use those things because she got Cushing's, and she got hypertension and Cushing's, from the steroids, from those things that she was using. Again, you hear where she's getting from. Mombasa House. It's called, I think, somewhere in River Road or somewhere in town, Nairobi CBD. Okay. Yeah. So that I was just giving as an example. So we move on. So these are the different causes of secondary hypertension, the same as I showed earlier. And I This is not so clear, that's why I had the other ones. But this one divides and talks about actual diseases that you could see, the same as the other places, mentions even some of the other drugs. We now move from the classification, we've looked at etiology of essential, we look at the hypothesis of the essential, sorry, and then the etiology of secondary. Before I move to this, give you a take home message that anytime you have high blood pressure, especially in the young, look at it as a secondary hypertension. And therefore, look for an etiology. Because if we are able to treat the etiology, then we will take that person back to normotensive state. Okay? That's my take home message. And I gave you examples, typical examples of what I've come across in practice. So please just do that for those patients. Okay? And I'm sure people have maybe stories or experiences that they've had in the past of the same. So now we've looked at this hypertension, we've looked at normal, but and we said it's more in the vessels, meaning it is called systemic arterial hypertension or systemic vascular hypertension. And what do we see in the vessel? So for the large and medium vessels, we will see atherosclerosis. For the Dr. Githinji, so I'll not go into that. So we look at the smaller vessels, okay? And in the smaller vessels, we have two pathologies that we see. One is the hyaline atherosclerosis, and the other one is hyperplastic atherosclerosis. Okay? So we look at the two in detail. For atherosclerosis, we've done in the previous class. So let's start with hyaline. And hyaline, just by mentioning hyaline, how we see it under the microscope is some pink, beautiful, homogeneous thing, pink, hyaline pink. Okay? Sclerosis, atherosclerosis, not athero, because it's, athero is atheromas, which is the fat plaques, but in arterial, it's a thing, a change in the arterial, in the artery. Okay, in the arterioles. Here we're not having fat deposition, and I'll show you what we are having. Okay, so hyaline, as I said, is a homogeneous pink thickening of the wall of the small arterioles of the blood vessel, so they become thick, and then the structures below it are even obliterated. They're lost. Okay, and therefore, because it's thickening, the lumen, the hole is decreased. Okay, it becomes narrow. Okay. When do we see these? Frequently in old patients. Okay, whether they are normotensive or hypertensive, we see a bit of this atherosclerosis, hyaline type. And then it's also a common finding in diabetes mellitus. As we will see in diabetes, we have big vessel diabetes complication and small vessel diabetic complication. So for the small vessel diabetic complication, we see the hyaline atherosclerosis. And then for generally, you'll see it as a more generalized thing in more severe in patients with hypertension. Okay, what is the result? Where do we get this hyaline deposition? Okay, usually it's because of leakage. You see, when you're having hypertension, the hemodynamics have been affected. We discussed hemodynamics in general pathology. So there's a chronic change in the hemodynamics of the blood. It's a chronic thing. It's going on for a long duration. So in that process, we'll have leakage. Okay, we'll have leakage of the components in the plasma, and now because of that, they leak across the endothelium, the vascular endothelium, and with that, there's reaction, of course. And how does the body react? We already did that. We'll have excess deposition of the extracellular matrix, and this is what causes the thickening, the hyaline thickening. So we'll have, and how do you lay extracellular matrix? By proliferation of your smooth muscle cells, which lay down that extracellular matrix. That we did last in general pathology, so I'll not go back. But that's how we get that hyaline thickening that we see in benign nephrosclerosis. atherosclerosis. Again, when you go to the kidney, we'll discuss benign nephrosclerosis as a very small topic. I think it's me who will do that. A very small topic that we'll talk about. Yeah. So here is where you'll have impaired renal blood supply again, with nephrons getting lost, and we see the whole picture in secondary hypertension. Okay. That's hyaline uh, atherosclerosis. So we go to hyperplastic. Just from the name, it means this hyperplasia. Okay, so this one is related to a more acute or severe elevations of the blood pressure. The other one I said it was chronic hemodynamics. Okay, something that has been going on for long duration, and that's how having the leakage of the plasma components. But now this hyperplastic one is more of an acute, or when you have very severe increase in blood pressure. Okay, it's a characteristic mainly, but not limited. You could get it in the others, but it's more of the malignant hypertension. We see it a lot in the malignant hypertension. Okay. And here we'll see the diastolic, as I said earlier, greater than 120 millimeters of mercury. Okay. Of course, by the time you're getting that, you'll have a bit of cerebral brain bleeds or kidney injury. Okay. Because of decreased supply. Okay. Yeah. So, what happens? How do we get this hyperplastic arteriosclerosis? This one is because the smooth muscle cells in the intima are now proliferating, and then they're also duplicating the basement membrane. Okay, so that's how it gets thickened. But this one, we're able to see the smooth muscle cells, and they form this thing like an onion. I'll show you that. You know, when you have the onions, forget about spring onions. These are the ones which have like a mbegu. I'll show you those onions. The way it goes round, that's how the hyperplastic atherosclerosis usually looks like. And I'll show you right now in a photo. Just before I show you, I'll just mention that in the malignant hypertension, which is characteristic of this hyperplastic atherosclerosis, these hyperplastic changes sometimes end up having fibrinoid necrosis. We did that, fibrinoid deposits within the vessel wall with necrosis. I know when we did hypertension, we looked at different patterns of necrosis. When you did necrosis, cell death in general pathology, and we mentioned fibrinoid necrosis. So it is seen again in this malignant hypertension. Yeah. And I show you the photos that I'm talking about. So here is the hyaline. You see this pink, nice, beautiful coloration. Okay, this is the hyaline deposition that we see. Okay, which is what we are seeing in this photo. The hyaline atherosclerosis. This is real now. This was drawn, if you could say that, but this is actual histological. What we see. Okay, this very nice. This is a blood vessel. If you look at the lumen, it's becoming narrow. Okay, it's almost it's like stenosis. It's narrowed. This is the hyaline. You see this pink, nice, homogeneous thickening of the blood vessel. Now we move to hyperplastic. So hyperplastic, I said the smooth muscle cells are proliferating. These ones that you're seeing here, these are the smooth muscle cells proliferating. And as I said, sometimes with the malignant hypertension, we'll get fibrinoid necrosis. So here we see the smooth muscle cells. Then in between, we'll see our neutrophils there. Okay, our neutrophils are also there with the necrosis. So the fibrinoid necrosis. Okay, this one that we see. So again, on this side, I show you the hyperplastic arterial sclerosis. Here we are, the onion skin like here, like this, round, like that. Again, even here, the lumen is narrowed. So the onion that I'm talking about, the bulb onion, that's the word, bulb, not spring. Spring is the ones that are having leaves, the ones that we make our salads, tiny leaves. Here is our spring. Okay, so you look at this, the onion skin appearance. This is what we are seeing with our hyperplastic. Yes, so that's something I wanted to show you on the vascular pathology that we see in this hypertension. So now we move to clinical features. And I pause there and I ask the class, how do you think patients with this hypertension will present, or what you have seen in the past? How did your patients present, the patients with hypertension? How did they present? Start chatting, please. How do the patients with hypertension present? Your patients with hypertension, how do they present? Nobody's writing. Yeah, good. Timothy, headache, correct. Keep typing. Huh? We only have one. Tracy, did you have something in mind with tobacco? Tracy and tobacco, do you have something in mind? A presentation? Dizziness, yes, Newton. Okay. Dizziness, okay. I see headache, blood vision, correct. Nose bleeding, very good. Chepkemoy. Breathlessness, very true. Augustine. Shortness of breath, etc. I see, very good. Sometimes they may have chest pain. Sometimes, they will even end up having, maybe they'll have an MI. Okay. So I see where we are coming from. So correct. So let's look at these clinical manifestations. So this was my first slide. Okay. So many times it's asymptomatic, no symptoms. Okay. Yeah, you're just going on with your general things until you go to a wellness camp and then they take your pressure and you realize, oh my goodness, I've been walking around with high blood pressure. And no, that time it's working on your organs, causing problems, those complications. Any other possible symptoms that we'll see is a headache that has been said, awareness of our heartbeat, which is palpitation. Sometimes some people have tinnitus in the ears, okay. Blood vision already mentioned, fatigue, and the nose bleeding, the epistaxis, although it's rare, but it's there. You have to really think about it. And then there are those who will now present with an emergency, hypertensive emergency symptoms. The ones that we've just said in the chat box, chest pain. Now, here it means they're already having complications of hypertension. Either they have an acute coronary syndrome or they're even having an aortic dissection. This chest pain, either an MI, Then people with dyspnea, already they are probably having left ventricular failure after hypertrophy. Neurological symptoms that they would present, like a stroke, because they had a bleed in the brain, okay? Or seizures. They just get into seizures, fits like an epileptic. Okay? Yeah, so these are different ways that the patients can manifest during this. So you have to have a high index of suspicion, but generally the advantage we get is because every time the patient comes to the hospital, our first thing is to, at the triage is also to look at their blood pressure. So we're able to pick, okay, at that level. Then you go down to check if, for example, if they present disease, it means they are already having complications of hypertension. And therefore, we move to the complications. Okay, the complications. And these are the complications. I put them down this way, okay, of our hypertension, the complications of our hypertension. So, as I said, different body systems will be affected. I know many times I bring a human body, a diagram, then I say from the eyes all the way to the toes. I also thought this looked nice because it breaks down the different systems. So you can have in the eye, and we already saw even in malignant hypertension where they get retinal exudates and hemorrhages. So in the eye, they can have hypertensive retinopathy. It's a common thing. It's a common thing. I've seen diabetes and hypertensives having even cataract, etc. So we just call it hypertensive retinopathy. This will be discussed during the diseases of the eye along one time. Then cardiovascular disorder, cerebrovascular disorders, where we have the ischemic or hemorrhagic ischemic disease, stroke. Let's call it stroke for today, but that's the right thing, ischemic or hemorrhagic. They might have hypertensive encephalopathy. We'll discuss those when we go to cerebrovascular system. Cognitive decline, and even dementia, So those are complications that we can have. In the cardiac, we can have cardiac hypertrophy, which is a common thing. We may have heart failure, and we can have also coronary heart disease, okay, the acute coronary syndromes. Okay, then renal will have hypertensive nephropathy and chronic kidney disease. It's really funny that hypertension can be due to the kidney. I give you a long list of kidney being a secondary cause of hypertension. Like if you have renal artery stenosis, you know, or you have a renin secreting tumor. And funny enough, the other side of the coin is that hypertension can cause chronic kidney disease. In my master's, in my MEd, I looked at um, chronic kidney disease and the changes that we'll get. And many of my patients who had chronic kidney disease, actually the main three diseases that are found in the chronic kidney disease category was hypertension, diabetes, and polycystic kidney disease. So it's an interplay. Hypertension will cause kidney disease, and kidney disease can cause hypertension. Okay, then peripheral disease like your aneurysms. Okay, yes. So we come to the end of the first part of our class. Okay, and these are just things for you to remember, that if you see the patients, what do you want to do? Okay, you have to check the BP, both arms. Again, this is when you're suspecting aortic dissection. Always assess target organ damage, because I say it's a silent killer. So by the time you're coming to the hospital, it's been there for some time. So look at the target organs. Do we have complications? These are the target organs. Check whether we have any complications. So you do tests for that. It's good to consider ambulatory and home monitoring so that you take away the white coat effect, which I explained at the beginning. Again, of importance is looking for the secondary causes, especially in the young refractory or symptomatic patients. Look for a cause. It's not just essential hypertension. There must be a cause somewhere along the way. Then, talking about lifestyle modifications, we've looked at those things that are making essential hypertension, the genetic part being modified by um, an environmental fact, like do physical activity, decrease weight, decrease salt intake, etc. And then monitor. When you have your hypertensive, you have to monitor the kidney. I've already mentioned why. Okay, even not only when they are on treatment, but even so that the hypertension doesn't cause kidney disease. And then adherence to management. Okay, so that's it for the first part. The next part is the heart disease. The complication, we've seen different complications, and because we are in cardiovascular, we have to finish with the one of the heart so that we don't go back to it again. Okay, we go to the cerebellum for the heart. So hypertensive heart disease. Hypertensive heart disease. I pause there and ask, what do you remember when you talked about hypertensive heart disease, or when you talked about the heart? A topic we covered in the first class about what the heart will do, or what will happen to the heart when we're having hypertension, changes that will occur to the heart when you have hypertension. This was in our first class of pathology. I'll give you a hint, or just I give you people time. I'll give you a hint. Okay, the hint is cellular adaptation. How did the heart adapt to hypertension? I see Benson is typing, Timothy is typing. Again, the hint worked very well. Multiple users are typing. Maybe one of you can just unmute and say. Very many people are typing. Left ventricular hypertrophy, correct. Because it's pumping very far. Hypertrophy, left ventricle hypertrophy. Thank you. That's what I was looking for. And that's mainly the main change that we see in the heart. Okay? So, what is hypertensive heart disease? This one will refer to the structural and functional change. Remember, that's what disease is, structure and function, in the heart, that is due to the chronic hypertension, systemic hypertension. Okay? The changes will increase the risk of heart failure, getting arrhythmias, getting ischemic, MI, ischemic events, etc. These structural and functional changes will lead to these risks, okay, occurring. What is important is that chronic elevated blood pressure will always increase the afterload, okay, on the heart. And then because of that increase, the heart will adopt by increasing the left ventricle, okay? That is an adaptive method. You'll have hypertrophy, as we said in the group. But remember, as we said in our class, that sometimes hypertrophy will get to the limit, elastic limit, okay, and becomes maladaptive. So you'll have a patient getting heart failure, for example, having arrhythmias. We'll mention those in a few, okay? So I'll just go through. My first one is the most important, the changes that we can see and the mechanism leading to the change. Then we look at morphology and then we finish, okay? So I start with the left ventricular hypertrophy that we've mentioned, okay? What is the mechanism behind it? Of course, it's because of the increased afterload, okay? And so the left ventricle will generate high pressure so that it's able to eject the blood. And remember, this blood is being sent further because it's now to the aorta, to the different parts of the body. So it needs to generate that, energy, high pressure. And how will it do that? It will increase, it will adapt by hypertrophy, okay? Thickening of the wall. The wall becomes thick, then it's able to push, okay? And I show you. This is the wall. In left normal is like this. In hypertrophy, you see how big this is. Okay, it can be even more than 4 centimeters. It increases that much. Okay, and of course, the weight of the heart is also going to increase. And you'll read about these laws. You guys have done that. So initially, it will be to compensate for the increased afterload, but with time, because of that thickness being so high, as we've seen in the photo, then it's going to reduce the coronary arteries may not be able to reach even of the enlarged or thickened wall. So it will become fibrotic, because healing with fibrosis, okay, and become very stiff, okay? That's how the wall will be like. And this is how eventually it leads to heart failure, okay? So consequences is that it will impair now when it's thickened like that, the diastolic, the feeling, during diastole, the blood feels inside the chamber. So this is going to be impaired because now the wall is so thickened, okay? So we'll have a diastolic dysfunction, and that now is the heart failure that is coming, okay? So we're not going to details of the way we say about ejection fraction, etc., but just know heart failure has now come in because the wall is too thickened, so it's not able to eject the blood out, neither all the blood as it should, and then neither is it able to fill. The chamber is not able to fill properly during diastole, okay? And this can increase the chances of arrhythmias, okay? Okay, and of note, as we said earlier, left ventricular hypertrophy is an independent risk factor for cardiovascular events like your myocardial infarction and, of course, mortality, death, okay? So let's look at this adaptive method. The take-home message here is hypertrophy, okay? So which are the different patterns that we can have of this hypertrophy? So there are two. There's one of pressure overload, okay? And of note is that these things will reflect the nature of the initiating stimulus. What do I mean by that? We could have pressure overload because of chronic systemic hypertension, or because the aortic valve is stenosed, is narrowed, okay? So the overload, the one we're having, pressure, we have to push it. We have to generate a lot of pressure to push it against this narrowed aortic valve, or the resistant vascular, peripheral vasculature, okay, in hypertension. Okay, so by so doing, the pattern of hypertrophy that we'll get is concentric. How the myocardium will behave, it will have a concentric hypertrophy, okay? So it will increase the thickness of the wall, okay? And of course, the diameter of the lumen will become smaller. Now, in contrast, if the stimulus is aortic valve insufficiency, it is not working normally, okay? It's not stenosis, it's just working not normally. I know we talked about valvular heart disease. So in volume overload too much, the characteristic thing is that we'll have hypertrophy, and this hypertrophy will be associated with dilatation we'll have now that chamber dilating to take care of this volume. Okay, so I have just put that last sentence, which you'll read during your last free time, but it just says that wall thickness is by itself not an adequate measure of hypertrophy due to volume overload, because you see, there's dilatation that has occurred. Okay, I show you on pictures. I like pictures because they help you understand. Now, here is because of hypertension or aortic valve stenosis. So here we are having pressure overload, okay, in our ventricle. And you see now what it has done? It has thickened. Look at this wall, very thickened, okay? Compare it to our normal. Okay, this is not as thickened as this. Now let's move to the other side where we're having volume overload on this side. So the wall thickened, yes, but there was dilatation. Dilatation. If you look at this ventricle, it is dilated. Dilated. So this is what I was saying. Depending on the stimulus, so on this side is aortic insufficiency, valve of the valve insufficiency, it causes more of a dilatation. Okay, compared to the stenosis, which causes this instead of dilatation is sort of a constriction. Okay, yes, okay. Left ventricular hypertrophy is one of the major things that I want you to take home today. The other things I would mention is because of the hypertrophy. So the next one I'll talk about is this: we are seeing diastolic dysfunction, okay, in the pathophysiology. So diastolic dysfunction, you saw it as a consequence of the left ventricular hypertrophy. That during diastole we are not able to uh, have enough of the blood. Okay, so the stiff hypertrophied myocardium is not able to relax properly. Okay, during diastole, so we will not have enough filling in the ventricle, the blood filling in the ventricle. Okay, so this will lead to elevated left ventricular and diastolic pressure. Okay, and that what happens, moves backwards and causes venous congestion. Okay, in the pulmonary, okay, veins. Okay, so with the time we end up having our heart failure. I'm just picking the main things we end up having. So the consequences when you have heart failure, patient will have tests, as we were told, breathlessness, fatigue, orthopnea, okay, tachycardia, fluid overload, they will present with all that. Again, this diastolic dysfunction is because we are not feeling properly, because the muscle is already stiff. Okay, so heart failure is another consequence that we would have. Okay, and another one is that now we may have enlargement of the atrium. Now from the ventricle, left ventricle, to the left atrium. Remember, blood is coming to the left atrium, then left ventricle, then aorta. So in all these changes, we may have left atrial enlargement, okay, because of the diastolic dysfunction, which now increases the pressure in the artery, okay, and the volume also again in the artery as it's going back to pulmonary venous, okay, increase, okay. Again, you overstretch because of that, the electrical currents. You remember how you have all that you see in your ECG. You'll end up having an AFib. AFib is atrial fibrillation. Okay, you'll end up having that. So consequences: loss of atrial contraction worsens the feeling, irregular pulses, which we'll see even on your ECG. Okay, patient will have palpitations. This can increase the chances of ischemic or hemorrhagic effects in the brain. Okay, and then the atrial fibrillation will worsen the heart failure symptoms also. Okay, so we're just saying this consequence of this consequence of this. Okay, again, now the main thing that we said as heart failure, again, heart failure is coming in because the heart is now has reached the maladaptive stage, the limit. Okay, initially because it was so stiff, so diastolic, it could not feel properly, but with time, because of the long-standing pressure overload and the ischemia, because some cells, because it has thickened so much, are not getting enough blood, they're ischemic, will eventually have even a systolic dysfunction, not just diastolic, but even systolic. Okay, so we have this of the myocyte fibrosis. Okay, we try to remodel, and then the heart is not able to do its contraction properly. So we have loss of all this, and we have heart failure. heart failure coming in. And that's how they'll have the symptoms we mentioned in the group. Okay. Sometimes with these, there's what you'll hear us saying we have a gallop sign. When you're listening to the heartbeat and the murmurs, it will be like people have you gone to Apollo? They have one in Jamhuri sometimes in Nairobi, or even when you watch those polo things and the horses are, in the gallop, then they're going boom, 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 boom. So when you listen to the heart of those people, you'll hear an S3 and S4 sign, at the heartbeat. Then you just hear S1, S2, do-do, do-do. That's how the heartbeat, do-do, do-do. But now in this other one is like a gallop, boom, 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 boom. You're having extra heart sounds, like gallop, like the horses going down that track. Yeah. So we hear that when they have this form of heart failure. And again, because of pulmonary congestion, they'll have crepitations. When you listen to the lungs, they'll have grr, grr, grr. I like saying what you hear on the stethoscope. Yeah. Okay. So the other thing, again, with all this going on, is coronary artery disease or ischemia, which we have discussed. That hypertension will accelerate atherosclerosis, and then the coronary arteries are not able to supply enough, especially to this muscle that has hypertrophied, which, of course, now their oxygen demand is higher. So you'll end up having sometimes ischemia, and especially subendothelial. Remember, your artery is on the outside, the coronary artery. So the things inside the chamber, subendothelium, may not get blood at all, just below. There's some that is diffusing directly from the chamber, but there's a one in between that may not get enough. That's the subendocardial ischemia. Mm. So you'll have angina, you'll have MI, etc. in these patients. But take home message, the last one is the arrhythmias that you may have, or sudden cardiac death, which we have discussed in the previous classes. Again, the changes that we saw, the fibrosis, the electrical remodeling, will increase the chances of arrhythmias. Okay. And the commonest is atrial fibrillation, although sometimes we can have ventricular arrhythmias. Okay. Yeah. Mm. So again, these are the presentations, the same irregular rhythm, heart rhythm. Yeah. So take home message is the left ventricular hypertrophy is causing these things, all of them, the ones I have mentioned, ventricular hypertrophy, which then predisposes to all these other things. The main thing we see is this left ventricular hypertrophy, which will predispose to diastolic dysfunction. Diastolic dysfunction then now leads to heart failure. Then hypertrophy. Okay, in hypertensive heart disease. Okay, so morphology we had already seen that will have thickening of the left ventricle. We have the concentric one, then we have the dilatation one depending on the cause, which is actual aortic insufficiency that will cause that. Of note is that we'll have cardiomegaly. I'll give you an assignment. Just go and check. You'll find it in your Kumar, Robbins and Cotran. You'll find that the heart increases. It can even be double the size, and it increases with different weights. So you'll see, like they'll tell you in mitral valve stenosis or in aortic valve, this is the heart, the sizes of the heart, that approximate increase in the size of the heart. Go read. We get a cardiomegaly. Okay, and that's how we tell when you're examining a patient. If the apex beat is displaced, then you suspect that they are having a cardiomegaly, and you can confirm it on a chest X-ray. But check, like me at autopsy, I'll be able to weigh and tell you that this heart was big. This one I did with my group earlier this year, and that's what the patient had. He had a cardiomegaly and a known hypertensive for a long duration. Okay, yeah. Then these are the things, of course, that are occurring microscopically. Okay, just talking about this is one of those that we do at autopsy. Actually, the one I wanted to show you is just that now I had to change laptops. Is one we did, I think, this year. It was this year, yes, of a humongous heart. It just couldn't change to this other laptop. I'm sorry. Yeah, so it's this one we have just sliced it. You can see how this muscle is enlarged from here till the lumen is small. Okay. Same as here on the transverse. This whole muscle like this. That's hypertrophy. Okay. So these patients, how will they present the clinical manifestations of hypertensive heart disease? Again, asymptomatic in early stages, but symptomatic later. The heart is failing. So they will have dyspnea, as we said, especially on exertion. You're trying to climb the staircase, nothing, you can't, you have to rest. They have easy fatigability, dyspnea, they're unable to even breathe. They'll have fatigue, they'll have palpitations. You're just there and you can tell that your heart is beating, ding, 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 ding. They'll have angina, we discussed those. Then they'll have signs of heart failure. They'll have edema, peripheral edema in heart failure. You have orthopnea. Like you can't lie down. Even when they're sleeping, they'll do that 45-degree or 30-degree pillow because now with heart failure, the fluid goes now to the pulmonary, as we said, system, and so you're congested. So even breathing becomes a problem. So they have that, and sometimes they'll have what we call paroxysmal nocturnal dyspnea, where they have at night nocturnal. They have to keep on, the breathing is affected. So they have to have that pillow, or they have to wake up and breathe and continue. Okay, and then they'll have a raised JVP, jugular venous pressure. Okay, which we usually measure. Okay, in the hospital, you'll just see from the jugular. Okay, and then complications are all the ones we mentioned. So we said heart failure, we said AFib, we said coronary artery disease and MI, then we said sudden cardiac death. All these are possible complications with this hypertensive heart disease. So we've mentioned all of them. So how do you make the diagnosis? Clinical assessment, of course, you look for all those things that we mentioned in clinical manifestations. Measure the BP, which is elevated. Then the investigations you can do an ECG, where you're able to pick the arrhythmias and the left ventricular hypertrophy. You do echo, which is usually the gold standard for detecting the left ventricular hypertrophy and systolic dysfunction. If you do a chest X-ray, you'll be able to see the cardiomegaly and the congestion, especially if they have heart failure in the pulmonary system. Then you do biomarkers of cardiac disease. You did that in clinical chemistry. So the one we use for heart failure is your pro-BNP. Okay, so you do it. Okay, pro-BNP. Then blood tests, just look at renal function, look at those risk factors, all those things. And especially if they're on treatment, just so you monitor the effects of treatment. Okay, so that's for diagnosis. Then management, again, control the BP. So that you don't progress to heart failure. Then manage the complications if you have any. Then pharmacologically, you'll use drugs like the antihypertensives, you'll treat heart failure, manage AFib, atrial fibrillation, and then you can do statins, especially this dyslipidemia. I don't go into details of treatment. Remember, I'm a pathologist. Non-pharmacological, of course, the things we said, that we are modifying weight loss, decreasing salt intake, doing physical activity, stop smoking, and I say stop taking alcohol. This thing of moderation is neither here nor there. I don't know what you think. And then the other thing, just follow up on monitoring. These are important things that you do. Regular checking of BP. Many times we'll even ask patients if they're able to buy a BP machine or go to the nearest health center. Then you can have the annual ECG and echo. Okay, then monitor renal function, encourage life surveillance, the medication, at least so that they comply. Then, it helps with prognosis, that you don't get into heart failure. The prognosis will be very good if hypertension is controlled early. Okay, yeah, and then you remember cardiovascular events. Having the left ventricular hypertrophy is a risk of MI. Okay, so I'm now just approaching the last part of my lecture. So I first pause there and ask questions up to where we are as we go to the last part. So we looked at hypertension, systemic hypertension, vascular disease in general, everywhere. Then we picked one of the complications, which is in the heart, and we've discussed all those things about the heart. Now I want us to go to pulmonary hypertension. Yeah. Are we together? Okay. So we move to the next one, which is pulmonary hypertensive heart disease. sorry, I said a pulmonary hypertension. That one we'll discuss in next topic. Yeah? This is pulmonary hypertensive heart disease. We are still in the heart, in the cardiovascular. That actually hypertensive heart disease can affect the pulmonary, and we've seen it in the previous slide when we were talking about atrial and diastolic dysfunction and atrial enlargement. So now the pulmonary hypertensive heart disease, the copulmonale, that's what we'll call it. What is it made of? It consists of right ventricular hypertrophy and dilatation. Okay. And this one is because of pulmonary hypertension. Okay. Either because of primary disorders of the lung parenchyma or primary disorders of the vasculature in the lung. Okay. So in short, copulmonale develops in response to increased resistance in the circulation in the pulmonary bed. So you have to know that it excludes right ventricular dysfunction due to left-sided heart disease or heart failure or any congenital heart defects. You already did heart failure with Dr. Gidinji. So you looked at right-sided heart failure, left-sided. No, we are not. We're talking about the parenchyma causing a problem with the ventricle. Okay, so that's why I said we exclude that. Okay? So how do we classify this pulmonary hypertensive heart disease or copulmonale? It can either be an acute process or a chronic process. Let's look at acute, short duration. Acute usually follows a massive emboli, a massive pulmonary emboli, which will obstruct the vasculature, more than 50% of the vasculature in the lung. Okay, massive. It's a lot. Emboli. We did embolism. Okay, so that when it blocks that, we get into copulmonale. Then that's the acute one. Then for chronic, it's secondary to prolonged pressure overload, over duration, chronic, taking time. Okay, and this is obstruction of the vasculature or compression of the capillaries, etc. And this is mainly because of those diseases in the lung, like emphysema, interstitial pulmonary fibrosis, primary pulmonary hypertension. We'll discuss those. We are going into lung. I think we even started. So respiratory. So we'll see those disorders. Okay. So, and these are the ones I'm talking about, the causes of copulmonale, diseases of the parenchyma, which we'll be discussing as we move along, like your chronic obstructive pulmonary diseases. We'll look at the diseases of the pulmonary vessels, okay, your thromboembolism, the hypertension, okay, or drug-induced ones. Then we look at diseases affecting the chest movement, either because you have structural problem like kyphoscoliosis or kyphosis and scoliosis, or a muscular disorder, neuromuscular disorder, or disorders which are affecting the pulmonary artery constriction, which could be metabolic ones, or even the obstructive sleep apnea we talked about earlier. So this would cause a lot of chronic, okay, copulmonale. Okay, so what do we see? The step-by-step mechanism of us developing that, us developing this right ventricular hypertrophy with dilatation. Right ventricular hypertrophy and dilatation. Step by step. Again, we have obstructed the vasculature. So what do we get? Hypoxia. Okay. And when you have hypoxia, they will have vasoconstriction as an adaptive method. But now, with all that, with vasoconstriction, we'll have remodeling, okay, of these arteries. So we'll have fibrosis, okay. With the time, we have even hypertrophy of the media, okay, within the vessel. And what will that lead to? Again, we go back and it will cause increase in the resistance in the vessels. And that's how we get the hypertension. Remember, hypertension, we don't forget, is vascular resistance. And now in the lung. So it just increases that, and we have pulmonary hypertension. So what happens is that the right ventricle now will face increased afterload, okay? And therefore, what will it do? It will adapt by hypertrophy, just like we saw in the left ventricle. And this can lead to dilatation and heart failure, okay? Yes, so that's how it goes. So the stimulus here is in the lung, okay? The stimulus here is in the lung. And like in the left ventricle, the stimulus was in the hypertension, the peripheral hypertension, okay? Or the aortic valve, okay? So morphologically, in acute corpopulmonale, what do we see? The right ventricle is usually dilated, but it does not show a lot of hypertrophy. And if an emboli causes death, sudden death, the heart may even be of normal size, that it had not hypertrophied that much. Of course, when you have an emboli, it can cause death. I think we discussed that earlier. Then for the chronic one, we have the characteristics right ventricular hypertrophy, sometimes even with the right atrium, hypertrophy. And sometimes, if this hypertrophy is so in extreme cases, is so severe, can be even be like the one we had seen in the left ventricle. It can even become more than what we had seen when you were talking hypertensive heart disease. Okay, yeah, so that can happen. Okay, so the pulmonary arteries often contain the atheromatous plaques that we'll see, and other lesions when you have this long-standing pulmonary hypertension. When we dissect them, we see that at autopsy. So I just show you the, this is the one we are interested in. This one was the left ventricle. We are interested in the right ventricle, the hypertrophy of the right ventricle. Here we are. So it has hypertrophied here. Okay, you see it's thick and this dilatation. You just compare here. Okay, this is small, this is dilated and hypertrophied. This is in copulmonale. Okay, this we had already discussed earlier. Yeah. So how will the patient present? So again, early it's often asymptomatic, or it will be overshadowed by the lung disease. Remember, there's a lung disorder causing this. And then, of course, they will have the usual cause of congestion. They will have fatigue, exertional right heart failure. We discussed those. We'll have peripheral edema, we'll have raised JVP, we'll have raised jugular venous pressure, we'll have hepatomegaly, may have ascites, we'll have a loud P2, okay, when you listen to the heart sounds, okay. Then you may have a right parasternal heave. Wow, how do I explain? So when you put your hand, the patient is lying at 45 degrees in the ward, and they're lying down, and then you put your hand on your palm on the right side of the heart of the chest. You will see the hand moving. That's the parasternal heave. It's easier for me because I've seen some of those patients in the past. I think the first patient I saw when I was a medical student, and then during practice. Okay, I don't see them anymore that much now, but yeah, that's how it was like. Then in advanced hypoxic states, they may have cyanosis. Okay. Yeah. So how do you make diagnosis? Again, your ECG, your echo, your chest X-ray, your pro-BNP. Okay. You can do pulmonary function test to see. You may also do a CT angiogram. Just look at the vessels. Management. Oh, very important. Lung disease. Manage the underlying lung disease because it's the one which is causing our problem. If they are lacking oxygen, you can give diuretics, okay, and then refer to the specialist. That's all I wanted to discuss. Questions? I don't see. You can ask questions now. That's all your hypertension. If you have no questions, I'm going to create questions and bring for you in the next interaction so that we can discuss. Yes, Julius.
Yeah, can you comment on we have patients who present with high systolic pressure and low diastolic pressure. For example, you'll find someone has a blood pressure of maybe 140 to 150 and their diastolic pressure is about 80. Can you diagnose these patients as hypertensive?
Yes, you remember in my first slide when I looked at classification using the European Society, I picked it there and I said we'll not go into details. I usually would want you to send that patient to the specialist, refer to the specialist, because it's how they moderate the drugs or management that they would give those patients with this. We call it, let me take you back. I mentioned it, I brought it there in my slides here. You can see that I call it isolated systolic hypertension. Exactly what you've described, a high systolic with a normal diastolic. Yeah? So I prefer we send to, yes, because we may also have complications with that. So I prefer the that you, if you pick a patient with that, refer to the specialist. We have very many cardiologists now because this is how they manage the patients. So yes, it is there. It's even there in the classification. So I would say you have to refer.
I've also witnessed some ladies, pregnant ladies in their second trimester, their pressure drops down. Like I think in Kijabe, I saw a lady it's like 60/40. And then after a while, the pressure goes back to normal. I don't know whether you have had such experience.
Okay, now I think we discussed some things when we discussed hematology, and we looked at changes in hematological changes in pregnancy. Yeah? We looked at blood volume. There are changes that occur with blood volume, etc. Now, of importance, why we send patients for antenatal clinic, number one is we want to know their pressure before. If we knew pressure before, it is good, so that we'll not be saying that the blood pressure dropped or elevated. Now, in pregnancy, because of the presence of the placenta and the fetus, there are things that they release which are vasoconstrictors that would cause preeclampsia, hypertension because of the pregnancy. Okay. Now, if you say that in the second trimester, one of your patients, the pressure went down, I think there must have been an interplay. Either there was medication that was being given, or there are many other circumstances. Maybe you did not check, because obstetrics has many things that can be occurring in the patient. We know it's a physiological state, but there are many people, different people are different. So you could have been, it was not that they had, maybe they had an eclampsia, then you managed and became hypo, or there were other circumstances that maybe it was a normal, people who are optimal, low, like their pressures are usually 100/60 in the normal. Then the pregnancy increases or decreases the pressure. Obstetrics would have to look at that in detail. And it's an isolated case. So I think it must be having some things, because in my practice, I saw a million. Okay, let me say, not say a million, but I ran a lot of obstetrics and gynecology work for about 3 years, and I don't remember seeing such a case. So it's an isolated case that needs the obstetrician to look at.
Thank you.
But there are those things that occur with pregnancy. Yeah? You also have to refer back to what we said, the changes that occur. That was just hematological. There are many other changes, but I know in hematological, we also mentioned other things like even the blood volume, etc. So I must have been an isolated case, and thorough investigation must be done with an obstetrician's review. Here, I usually say we have the obstetrician and the physician, the internist. Okay, the internist. Okay, anything else? Direct management. It's because this is a sensitive one. We mismanage patients. If we are able to do referrals, and like how they manage the isolated systolic hypertension is in a unique way. So let that specialist, people who do that all the time, do it, and cascade it now to the others. But mainly because they're isolated cases, not an everyday case, let's refer. The same way as I said obstetrics, I haven't practiced it in like 10 years. Got that case, I will send to the obstetrician to manage it. Yeah, you'll see I talk about pathology mechanisms. I don't go in deep details about treatment. I just discovered sometimes, like last week, I was in a certain county doing the work, and so of course I was doing demos and establishing things, and this patient that I had, and I was doing the core needle biopsies of the breast as I'm teaching the people in the county, and so we had to prescribe some drugs, and I laughed when the radiologist stands and tells me, okay, doc, we need to prescribe. Then the surgeon laughs and says, I don't think the pathologist remembers how to prescribe. I even told them I have no prescription pad. So it's interesting, like I told them, maybe things have changed, and they laughed. But yeah. I don't that much. Okay, so we can call it a day. So I'll not send questions here. I am going to prepare some questions which we can discuss in our last class. I mean, in our next class, just to discuss, to see whether we have internalized hypertension. So I'll just prepare some questions. Then when I come in class, then maybe like we take a 5 minutes of just answering the questions and we see whether we internalized what we've learned today. Okay? So I leave you with this question. Is your blood pressure in control? You checked your blood pressure? If you haven't, I'm sure if you even came to our department, there's a BP machine. You can come, we check. I'm not there now, but yeah, you can pass by, we check. And I'm sure even in your department, there must be a BP machine. Yeah? Or in the nursing skills, the college has a nursing skills lab. It has a BP machine. Just walk in there, say, I want to learn how to take blood pressure. And of course, the assistant there will help you and you learn how to do it and you'll take on yourself too. That's how we learn. Okay, thank you very much. So back to you. Was it Victor or Faith?
Yes.
Okay, so we can call it a day?
I think so.
Okay, Sawa, thank you. So we'll do a recap of this physically, yeah? It's just that I'm away. There are so many things that we had put in play during this time of the year. Okay, so thank you very much. So we meet in the next class. We're going to discuss that in detail. Thank you.